Okay, so this is a 59-year-old man who's diagnosed with myeloma with 17p deletion at diagnosis. Is induced with VRD, followed by a stem cell transplant, and the patient is able to achieve the CR. And relapses 4 months later. So obviously, something has to be done. RVD is restarted, and patient fails to respond, and then we switch to CytoGenics, and it just lasts for a couple of months with a PR, and the patient starts showing plasmacytomas. What to do next?
So let's go to the
Real
questions
case.
with the options.
So the options being pomalidomide, carfilzomib-based regimen, second transplant, allotransplant, clinical trial with a novel agent, investigational monoclonals, or investigational antibody-drug conjugates. So I'm going to go back a little bit to talk about the subclones. You've heard plenty about that. I already explained how we reached this point, but I want to just delve a little bit further of why this is important. And I know it's pretty self-evident, but it's just really the ability of the cells to adapt. It's classic evolutionary principles. And at the end of the day, it's just that ability to adapt that makes the cells be able to overcome drug therapy. And I did allude to this briefly when I showed the slide, saying that it's been postulated that perhaps even at the time of diagnosis, you see these predominant clones, but there may be thousands, tens of thousands of different clones, each one of which contains already some of the mutations that ultimately will arise in the presence of this therapeutic challenge. Now, with my collaborator, Wei Yu Chang and Dr. Chung in Singapore, we actually studied this phenomenon a little bit further. And what we tried to do is we tried to establish whether measuring some form of this genomic instability. So all of what we can measure is the complexity of the karyotype. But we decided, okay, if we measure the complexity of the karyotype, we're going to assume that there was something that led to that complexity, and we're going to call that genomic instability. So by measuring that complexity, we actually could generate very clear survival differences for complex karyotypic abnormalities, which is something we've known for 30 years when we look at metaphases. But now this is through novel techniques like sequencing and single-cell analysis. So at the end of the day, what I'm thinking more and more is that as we move into the future, when we talk about high-risk myeloma, yes, we may use some markers. Some of them may be surrogate markers like 414 or -17. But at the end of the day, what we really are saying is myeloma that can adapt. And that's what makes it overcome our approaches to try to control it. And to second the point that Dr. Richardson made as well, I think that this is something that leads to efforts in combination. I've shown this slide sometimes before. This is one example of the most commonly appreciated marker as high-risk disease, the P53 deletions. And in this case, I mix them with mutations, which are quite rare at the time of diagnosis, but then they become common afterwards. And I'm just going to walk you through. At first, newly diagnosed patients, about 10% of patients have the abnormality. And then as you walk through the various lines of therapy, as a patient that Paul previously shown, first relapse goes up to 20%, second relapse goes up to 30%, plasma cell leukemia is close to 80% of patients, and the myeloma cell lines, essentially all of them have one abnormality or another of P53. Now, this is a gene we know about. It's been obviously studied extensively because of its important role in disease pathogenesis, but I think this is what we see with all of the other changes. So in a patient like this person had the 17p abnormalities. Clearly, clinically, even if we didn't have genetics, we know this person has high-risk disease. So what do we do? And the options are here as presented, of course, in the answers: pomalidomide, carfilzomib-based regimen, second stem cell transplant, allotransplant, clinical trials, or a number of immunotherapy or combinatorial approaches. Now, I won't belabor the point on pomalidomide, as we have talked quite a bit about this, but just to show again the waterfall plot showing that, in fact, it can be effective, and many of us have patients in our practices that, despite having some of these aggressive features, the myeloma cells don't read the book, and these patients will go on to get durable responses. I think most of us probably would not go with a single agent in someone who's failing RBD, but it's something that potentially could be tried. Now, I wanted to make a comment also about high risk, because risk is, in and of itself, is a complex topic, but it really applies mostly for the time of diagnosis. How do we incorporate risk down the line is a little bit trickier. So if you have a patient who, for instance, has a 414 intermediate risk by some of the new categories, but that patient is seeing fifth line of therapy, that patient does not have the biology of very high-risk disease. And therefore, it's one of the quote-unquote good 414s. It's been recently said that perhaps PomDex is able to overcome some of the abnormalities that are used to classify this high-risk disease. But when one starts looking at the actual numbers of survival differences, they really are trivial. So I'd like to propose that any patient who's double refractory in and of itself already has high-risk disease. And I wouldn't necessarily use this data to choose one regimen versus another. And this is some of the data that has been both presented at the ASH meeting and now published in JCO, looking at the effect of risk stratification for pomalidomide. And again, I would just be careful about this. We, of course, like to see responses. We see that sometimes in patients who have this high-risk markers. But then again, this does not extrapolate to interpretation of high-risk disease in the upfront setting. Okay, so what about carfilzomib? Obviously, we want to look at other possibilities. And I've elaborated on this, particularly in combinations. You know that this has been tried in patients who have prior exposure both to bortezomib and lenalidomide, ultimately led to the approval. In this patient population, an overall response rate of 30%, and then a median duration of response of about 8 months. So this would be kind of the natural next agent, but just using the slides that I had during my previous presentation, predominantly I will do this in a combinatorial strategies. As a refresher, I'm going to show the slides here for the study of Dr. Mikkel. I already showed the ones for Dr. Richardson as well too, of pomalidomide, bortezomib, and dexamethasone. I talked about the 25 patients, and I'll just say there's 9 in the phase 1 and 16 additional patients at the dose level 2. I'm sorry. And for those that are at dose level 2, again, a third of patients had this MSMART defined as high-risk status. The median prior lines of therapy was 3. Did mention 100% of them treated with prior lenalidomide, 75% with stem cell transplant, and again, a response rate which is a 94% rate. When you combine what has been shown by various speakers before, the single agent or agent plus dexamethasone, both for pomalidomide and carfilzomib, you see that these agents actually in combination are able to overcome and achieve above and beyond what we would do just with the addition of those response rates. Now, there's a good rationale for this. I know Paul already alluded to this. I do think that IMiDs are pleomorphic and have many abilities to actually induce sensitization to chemotherapy. Of course, effects that they may have in the immune system, but also the effects that they may have also on the processing of normal protein. And we and others are studying whether they actually sort of put the stage such that actually proteasome inhibitors can benefit from interference with the trafficking of proteins at the intracellular level for myeloma cells. I did mention too before the combination of CAR, pomalidomide, and dexamethasone, the study from Dr. Shah. I won't elaborate much on this, but again, just to show that the clinical benefit response of 83% in this heavily pretreated population. I think the reality is if any one of us sees a patient like this in the clinic, you would be concerned. You would probably try to go for a combinatorial approach, and any one of those regimens that we have talked about obviously makes sense, but we're committed to clinical trials, and that would be one of the things that we would be immediately thinking in a patient like this. I'd like to say that in closing that one could think as immunotherapy, and I think this is very interesting. It has been briefly mentioned before, but I think when one looks at the composition of cells that have high-risk disease, they still retain the majority of the cell surface markers. So people have referred to this as the extragenomic approaches to myeloma. I think there is no question that with sufficient time and incomplete killing, the subclones will arise just with small molecule approaches. In fact, I don't think that we will ever have a silver bullet for myeloma, much as we have a imatinib for chronic myelogenous leukemia. I think there's great potential for combinatorial strategies to do so with small molecule plus some of the agents we have. But in fact, and this is probably the third time you hear at this meeting, extragenomic approaches, so it's things like Daratumumab and other monoclonal antibodies, potentially could overcome some of the mechanisms for drug resistance that we have for high-risk disease. So if I had a clinical trial where I had the ability to put one of those patients in an immunotherapeutic approach, particularly if it was in combination with something else, because this is a patient that obviously clinically makes me very nervous. I think going into a phase 1 clinical trial with sort of escalating doses of a new monoclonal, I probably would have a hard time putting a patient in a trial like that. If I had a full dose anti-CD38 antibody, I would have full confidence of putting the patient in such a trial, understanding that the patient still has very high-risk disease. So I'm going to summarize. I think combinatorial strategies remain best for this patients. I think one point which was not really elaborated during the presentation of my case, for patients who have high-risk disease, it's really important to consider early introduction of therapy in the post-stem cell transplant period, particularly for -17 patients. I know this is tricky because we're talking about blood count, recovery of hematopoiesis, but it's something I'm quite mindful about. And I just say, practically speaking, it's good to bring up the topic with patients in anticipation of the transplant, so they don't get back to your clinic and they're surprised by a new discussion about potentially doing additional therapy. I'll put my vote for immunotherapy approaches just because of the effect of extragenomic approaches. And like I said during my previous talk, I think much more progress is needed. So with that, I'm going to close, and thank you, Bob.